use to make sure the name that is showing up for you here on Zoom is your full name, the name that you registered with, and one that I will recognize, not something like iPhone 6 or Mary iPhone. So go up on the top of your little screen there and change your name if it's not showing up as your full name. Thank you. All right. Well, welcome everyone. We're right at 12:30, so I'm going to go ahead and get started. My name is Sydney Palinkas, and I am the Community Outreach Education Manager for the Elder Safe Center. Thank you all for joining us today for our webinar on Mobile Integrated Health, a community-centered fire and EMS approach. Can you go to the next slide, please? All right, so just some webinar logistics before we get started. I'm sure you all know the gist already from 2 years of this pandemic. Please keep yourself muted throughout the presentation. However, we do want to hear from you, your questions and your comments. So put those in the chat box as we go through. We will definitely have time to get to those at the end. A copy of this recording and the PowerPoint will be sent out after the webinar. Next slide. All right, so if those of you looking for continuing education credits, this webinar does offer 1.5 Category 1 Social Work Maryland continuing education credits. In order to receive those, you do need to be present for the entire live webinar, and you need to make sure that the name that's showing up for you here on Zoom is your full name. If it's not, go up to the top of your little square and click on those 3 dots there and make sure that you have changed your name to something that I'll recognize. After the webinar, you'll receive an evaluation that you can complete and request a certificate. Certificates will be emailed out within a few days. If you have any questions, please feel free to email me, Sydney Palinkas at ceslc.org. I also want to note that we do have the live transcript option on right now for the webinar for those that need it. If you do not need it and you're finding it a little bit distracting at the bottom of your screen, you can go down to either the bottom or the top of your screen, depending on how you have your Zoom set up, and click hide the transcripts. Next webinar or next slide. All right, so just a quick introduction to the Elder Safe Center for those who are joining us for the first time. Elder Safe is located in Montgomery County, Maryland, which is why we're so excited to be partnering with Avital and Pili today, because they're in our local community, which is something different from a lot of our presenters. And we are serving folks in the area that are experiencing any form of abuse, neglect, or financial exploitation. We have a language accessible helpline that is open to professionals and older adults in the community. And we're also able to provide temporary safe shelter on our long-term care campus. In addition to that, we do lots of community education and advocacy. And we have started doing monthly national webinars on different topics related to abuse. And we're so glad that you joined us today. And I know many of you have joined us each month. So I am so excited to turn it over to our speakers today, talking about the Mobile Integrated Health Program here in Montgomery County. We have Avital Graves, who manages the Montgomery County Fire Rescue Service Mobile Integrated Health Program. She is a paramedic and has been part of the Montgomery County Fire and Rescue since 2002, and she joined the MIH team in 2019. And we have Pili Doe. Pili is a registered nurse, and since 2019, she has been in the role of community health nurse with the Montgomery County Department of Health and Human Services, serving as the primary nurse for Adult Protective Services and the Emergency Mobile Integrated Health Program with Montgomery County Fire and Rescue. She has over 10 years of experience, including working in critical care, the ICU, and as a clinical research nurse with the critical care department at the National Institutes of Health. So thank you both so much for joining us today, and I'm going to turn it over to you.
Great, thank you so much, Sydney, for that lovely introduction and overview. Can everyone hear me okay?
Yep, we can hear you.
Perfect. All right, so we're so excited to be able to share information about the MIH program that exists here in Montgomery County. We're not the only one, so we'll get into that, but we are a bit of a unique blend in Montgomery County, and we think we're probably one of the only models of this type around the country, really. So we're excited to share this with you because it does have a really great tie-in to the elder community, the senior community in Montgomery County and beyond. So we'll go ahead and get started here. So we'll do kind of just an overview of what MIH is, what we do. We'll talk about the Adult Protective Services Division of Health and Human Services, as well as the Crisis Center a little bit. We'll talk about where we're going and where we hope to be in the next few years. And then we'll share a case study with you guys about kind of a success story to some extent. Sydney, can you throw up that first poll question? So we just wanted to kind of get an idea of what folks kind of have in terms of interactions with fire rescue EMS already. So just in general, working with doesn't necessarily mean that there's a specific program, but just, do you have a point of contact? Is there someone that you know who to reach out to if you have questions or concerns? That kind of relationship doesn't have to be a standing program necessarily.
So we have lots of answers coming in. I will give it a couple more seconds. About 60% of the people have answered.
Yeah, I like this live real-time results view. It's really cool.
All right, if you haven't answered yet, go ahead and answer that poll now. And I will close it at the minute mark. Okay.
That's great. So a little more than half the folks have some kind of relationship, frequently or infrequently. And for those of you who don't know, hopefully by the end of this presentation, we can at least point you in the right direction for how to find the right folks in your area. All right, can I just close that out?
Yeah, I think it's closed.
All right. So the Mobile Integrated Health team that we have is comprised of a few different folks from different walks of life and experience levels and educational backgrounds, and that's very intentional. So I'm the manager. I have a fire rescue background. I'm a paramedic, and I've been in the fire service since 2002. We have a lead paramedic, Ari Singer. He is with us a few hours a week, part-time basis. We also have Pilly, who's on with us today, our nurse. Jennifer Forrester is the MIH social worker. Michael John is our dedicated data analyst, which is really critical to a program like this, to have someone who can in real time address the needs of the program and determine kind of where our gaps are in services. And then we have various interns, for the most part from University of Maryland, but for example, Pilly has an intern right now from Catholic University. So we take all the interns and free help we can get. The APS team who contributes, Pilly, do you want to review the APS team? You're muted. All right, I think Pilly's having some technical issues, so I'll keep going with this till she's able to get on. So Denise Breskin-Gambrell is the supervisor at APS who oversees clinically Pilly and Jennifer's efforts, and Mario Werthausen is the manager of APS, as well as some other aspects of protective care. So Pilly and Jennifer are just two important members of a very large team at APS, consisting of case managers and investigators, intake. You know, APS is just a well-oiled machine over there at HHS. So we all work closely together. We are in constant communication and contact about what's working and what's not working. And this really is what sets our MIH program apart from others around the state and around the country. So how we got here, MIH is not a new concept. It's been around for quite a few years now. The program in Montgomery County really kind of got going in 2017. It was envisioned as a fire department based program, and we sought support from the hospitals and their extended home health agencies to support the needs that we had clinically outside of a paramedic skills. So for example, if we needed a nurse or a social worker to come with us, we reached out to, you know, Holy Cross or Adventist and said, hey, can you spare a nurse to come with us on this home visit, or can we, you know, have a social worker consult on this case? And that was pretty much the extent of what we were working on. It was very much in its early phases, and pretty quickly we realized that we needed additional support really full time to make the program as successful as it could be. So the county executive at the time, Ike Leggett, pursued a funding model that would join HHS and fire rescue together, where the nurse and social worker positions would be managed clinically and funded by Health and Human Services and Adult Protective Services specifically, and then they would be detailed to fire rescue to work in the MIH program. This was a win for both programs. APS was looking for additional staffing at the time, and they were at capacity, so they got 2 additional positions out of this deal. And fire rescue got a dedicated nurse and social worker, which was exactly what we needed. So we've looked at the changing needs of the community around us, not only here in Montgomery County, but also in Maryland as a whole. So that was really a win for both of us, and we're ecstatic to be able to continue this partnership. So a lot of people just ask, well, what is it exactly that you do? And there's a lot of things that we do. The main role of MIH is to identify folks who have a high utilization rate of the EMS system. We don't have a hard, fast rule about, you know, if you've only called us 3 times, we can't work with you. But once you call us that 4th time, now we can start working with you. But we want to have folks in our circle who really do have some nexus to fire rescue. So if you've never encountered 911 services before, likely MIH is really not the program to engage on that person. But we keep ourselves plenty busy with the population that we serve here in Montgomery County. I'll get into some statistics about how many calls we run and you know, numbers of high utilizers in a little bit. So focusing on that population who does work or encounter fire rescue in some capacity, be it EMS transports to the hospital or lift assists at home or frequent calls for a non-existent gas leak, whatever it may be, we'll reach out to them and do care coordination on their behalf. We'll do resource partnership. We'll work on mobility and transportation needs. We don't provide those directly, but we can connect people to appropriate resources. We're community liaisons. Pili can assist with medication management. And we do home assessments as well for appropriate cases. So we are heavily referral based at this time. We do home visits and we can go out into the community when needed. But what we have found is that the referrals are really more beneficial in the long run and allows us to move through a heavier volume of patients and move through them more effectively. We work with a whole bunch of different folks all across the county and beyond. So we work very closely with HHS in a large regard to APS, but we also work with the Crisis Center. We work with Child Welfare Services. We work with Homeless Services and CEF. We work with all 4 hospital systems, which is 6 hospitals in the county. We work closely with our law enforcement partners. We work with the Gaithersburg Hoarding Task Force, CRISP, which is the Maryland Health Information Exchange. We partner with them so that every EMS run is put into that health information exchange so that hospitals can see the relevant information from an EMS transport. And we work with MIMS, our overall state EMS licensing and regulatory agency. So as far as what APS brings to the table, APS obviously has a long-standing place in our community. I think their services are typically well known by those who encounter them frequently, but we also often encounter folks who don't understand quite what it is that APS does. So APS just put this slide together for us so that we can kind of clarify for folks what they do and don't do. So, you know, they obviously focus a lot on assessments, and if necessary, they open investigations on patients, and they focus on care management and safety planning, victim assistance for those who are dealing with abuse or neglect. They partner very heavily with the county and helped create the Elder Vulnerable Adult Abuse Task Force. They work closely with the Ombudsman Program for long-term care. They work closely with our law enforcement partners as well. And then they have really a very seamless interaction and system set up within HHS for all of these divisions to work together. And then they use CJAMS, which is the State Health and Human Services System, for their EHR. So there's just a little bit more about that Elder Vulnerable Adult Abuse Task Force. It's multidisciplinary. It's really impressive to sit in on those meetings. They typically meet once a month, and basically it's a joint effort where you have law enforcement, adult protective services, state's attorney, county attorney's office, the ombudsman if necessary, and public health and guardianship all coming together to discuss these shared cases. And it really allows us to implement kind of quick solutions, discuss cases and share information in real time, and then determine kind of what the appropriate next steps are and who's going to take the lead on that. So it's really been a pleasure to work with that team. So getting into the history of MIH, we, like I said, we started around 2017. We really got into the kind of meat of the program, and it started originally as a white paper that was proposed by a couple of EMS captains who were in the field, and they really thought it would be great to start this kind of program in Montgomery County. Simultaneously, there were some conversations going on at the higher levels around community intervention and some other way to address the high utilizers of the EMS system. So really everything kind of came together at a good time. And originally, MIH was kind of touted as a cost savings program because frankly, that's what gets people on board for a lot of things. So they talked about how they could offset the cost of one ambulance, essentially. An ambulance will typically cost us, and this is even outdated numbers now, but usually about $1 million a year to fully staff and keep running. So it's not just the cost of the ambulance itself, which could be, you know, $250,000, but it's also the cost of the staff who's on the ambulance and the cost of the firehouse that the ambulance parks in, and the fuel and the maintenance and all of those things that go into it. So we thought, well, it would be great if we could offset the cost of an entire ambulance by cutting off, you know, certain high utilizers and preventing those calls from happening. So we typically run a total call volume of about 122,000 calls a year. So that's the total number of dispatched calls, for example, for 2021. In 2021, we also, out of those 122,000 calls, about 91,000 were EMS related. So that is definitely the bread and butter of the fire department in Montgomery County. We're a combination system where EMS and fire kind of live together under one house. And so majority of our interactions with the public involve some kind of medical emergency. And out of those 91,000-ish calls, about 70,000 were transported to the hospital. So you can see that, you know, transporting 70,000 patients to 6-ish hospitals, because sometimes we might go to Sibley or MedStar Washington Hospital Center or something like that, but for the most part, Montgomery County's hospitals are bearing the brunt of those 70,000 transports. So this was definitely something that piqued everyone's interest. We did see success on a micro level. We saw a reduction in call volume. We had an N of maybe 7 patients where we saw consistent reduction in their call volume and 911 usage after MIH intervened. And the interventions that we were doing were mostly focused around case management, connecting people to a primary care physician, medication management and reconciliation, calling pharmacies to make sure patients had adequate medication supply, calling insurance companies to make sure that, if there was DME equipment that was needed, we could get that arranged for the patient. Maybe looping in family to let them know what was going on and educate them about, their loved one's 911 usage, because sometimes they weren't always aware. It was very heavy on home visits. It used 2 paramedics at a time to go out. And then again, we were using that hospital side to supply either a social worker or nurse as needed. And we were really focusing on 1 patient at a time. The medics were bearing the brunt of that work. What we learned throughout the time that this model was running, and when I came on board in 2019, I kind of took a step back to see what was working and what wasn't working. And what we found was that home visits aren't always the most effective way to interact with a patient. They're helpful in some circumstances, but in other ways, they're very costly. And in some cases, what we were doing was just swapping out one crutch for another, right? So the patient stopped calling 911, but then instead started calling their paramedic who was assigned to them on a cell phone constantly. So we weren't really completely addressing the issue. We were just putting a Band-Aid on or making a swap for a different type of service. Also, paramedics are not great social workers or case managers, and that's through no fault of their own. They're completely different areas of expertise. And we needed more support from MIMS at the time. The guidelines were kind of very bare at the time, and I think that was intentional so that programs could really kind of build up what they wanted to build up. But we needed more support for a program that worked in Montgomery County as opposed to another jurisdiction. Because MIMS is a state licensing agency, the protocols that they make usually apply across the board to the entire state. So the protocol that an EMT follows in Queen Anne's is the same protocol that an EMT follows in Montgomery. And so we were trying to follow a model that worked really well for some other jurisdictions, like those that are less populated, have fewer resources, such as Queen Anne's on the Eastern Shore. But for us here in Montgomery County, with all the resources we have, we were finding that we were duplicating services that already existed in the community, and we weren't really doing the best job at it. So we kind of took a step back, and that was late 2019. And then we started looking at the data. So using that data analyst that our team has readily available, we started kind of combing through our data and trying to see who is it exactly that constitutes a high utilizer and who's using the system the most. My thought process was that if we could identify those high utilizer populations and find some trend or consistent need among those groups, that maybe we could have like a group approach to how we respond to those folks instead of identifying people one-on-one or by one, and making sure that we had solutions that applied to more people at once and could maybe help more people at once with less exertion and energy from the clinicians. So we don't do home visits anymore consistently. We really are much more of a referral-based system now. So we get around, I would say, about 800 referrals a year mostly from our clinicians in the field, our EMTs and paramedics. And I apologize for using the word clinician because I know it's confusing when there's social workers in the room. But our our EMS licensure system has been very specific that EMTs and paramedics in Maryland are to be called clinicians. So when I say clinicians, I'm referring to EMTs and paramedics. So the EMTs and paramedics who are in the field are making these referrals to us, and I'll show you some examples of what the referral forms look like and what we're asking them to tell us about these patients. And out of those, majority of them are either already connected to the resources they need. It's just a matter of connecting the dots and making sure that the resources they have are aware of the problem that's being generated, or it's a matter of creating those connections and saying, to the hospital, for example, hey, this person's really not a safe discharge home. We need to make alternative plans to ensure that they have a means to get home safely or be cared for appropriately before returning home. And we do home visits when we need to get eyes on the client. If we can't reach somebody, if we're trying really hard to get in touch with someone and we can't track them down, or if we just have a level of concern around their personal situation. So again, what we're learning is that home visits just haven't been as critical, and COVID really demonstrated that for us. We didn't do any home visits in 2020. We wanted to make sure that our staff was safe and wasn't being exposed unnecessarily to risk. So we really pivoted to much more of that referral model. And we have since reintroduced home visits. We did about 50 in 2021, and we're definitely on track to surpass that this year. We've also learned that MIH is a unifier. It's rare, I think, to find programs that can easily transcend and kind of cross lines between different departments, be them public or private, and really have a legitimate need to interact and work with all of those groups. And when MIH comes in, people are usually very willing to work with us and talk to us. People are usually excited to learn about our program. The public, if we call and do a follow-up to say, hey, we see that 911 was at your house, the clinicians who were on scene were really concerned about X, Y, and Z. I'm just calling to follow up and check if there's any services that we can help connect you with. They're pleasantly surprised. They don't know that the service exists in the county. They've never heard of it necessarily, and they're excited to learn about it. So that's been really nice. We've had improved access to behavioral health and APS services with this embedded model. So Pilly and Jennifer are able to get more information. There's kind of a sharing of data both ways, where obviously Pilly and Jennifer have access to a database on the APS side, as well as the fire rescue data from our EHR. So we're able to really give them get a better picture of what's going on with the patient in totality, not just our perspective on it or the APS perspective. We've also come to the unfortunate realization that there are going to be people who just continue to call 911, and no matter what we do, no matter how hard we try, no matter what resources we offer them, they're just going to continue to call. So we do have some patients where we just, we know they're there. When they get referred to us, we assure the clinicians that we're aware of them. We continue to reach out and offer resources or support as needed, and work with our community partners to do the same. But ultimately, we can't stop someone from calling 911, and the Montgomery County Fire Rescue System does not have a mechanism to refuse anybody service. So if you call 911, even if it's for a less than legitimate reason and you say you want to go to the hospital, we will take you to the hospital. We don't have any mechanism to refuse that service to you. We do want to be able to replicate and expand this service and this model to other areas. There are other MIH programs across the state that are thriving and doing really great work specific to their jurisdiction. But in general, we want to be able to take this idea of having this multidisciplinary team with an EMS clinician and social worker or nurse, or above, like, a different clinician altogether, a different license level altogether, and apply it to different areas of fire rescue. So where are we going? We have some really exciting things on the horizon. This is just a great time to really focus on behavioral health. I think everything is coming together in terms of local government, state government, federal government, really realizing that this is the time to take advantage and address some of these crises that emerged, especially during COVID. So one of the efforts that we're working with the county on is what's called a restoration center. Basically, it's an outpatient behavioral health center, and behavioral health in this context includes things like substance use disorder and those suffering with alcoholism and other drug abuse issues. So the restoration center is an outpatient kind of one-stop shop, 24/7, 365 operation. It's a no wrong door policy and approach, meaning patients who are brought there will be accepted regardless of what the presentation is. If it's not appropriate for the restoration center to handle, they make the moves to transfer the patient or move them to wherever they need to go. So we're really excited about that prospect, and the county is working tirelessly on that. Look for that in the mid to late 2020s, but we're very excited about that prospect. The enhanced crisis response, HHS has been going after a lot of grants and funding in order to expand crisis services in the county, and they're doing a great job of it. They have already been working on expanding their mobile crisis teams, and we'll talk a little bit about that later on in the presentation. We also work with HHS on a Leave Behind Narcan initiative. That is state-funded Narcan kits that are given to jurisdictions, HHS departments, in order to disseminate them to the public. So our HHS here in Montgomery County does virtual trainings. They did in-person trainings pre-COVID, but they'll do trainings or educational events, and anyone can get free Narcan kits to keep on their person or in their home, just in case. We encourage everybody to have Narcan because you really don't know who might have an opiate addiction that they suffer from, or what's happening more frequently is that people are taking medication that they think is legitimate, that they might buy from somebody that's not prescription based, and then they don't realize that there's fentanyl in it. So they unintentionally overdose. And even people who have a known drug addiction are getting substances that have more fentanyl than what they're used to, or more fentanyl than they've ever taken before, and they're overdosing. So we encourage people to take Narcan kits and keep them handy. And so to get more kits out to the public, we actually started carrying these Leave Behind kits on every single piece of apparatus in Montgomery County. So every fire engine, every ambulance, every chase car, all of them have Narcan kits on board, and they can give those to whoever wants them. It doesn't have to be related to an overdose call. It doesn't have to be related to an EMS call at all. And all of our firehouses now carry it too. So if you walk up to any firehouse in the county, you can ask for a Narcan kit and they will give you one, no questions asked. Please feel free to spread the word on that, because we'd love to get as many kits out to the public as possible. We work with the CEF team and the Healthcare for the Homeless team for the county, who just opened a new medical respite center for the homeless population. 3 houses on Fleet Street in Rockville, one specifically for women and 2 for men. Really a unique program that has such exciting ramifications for the homeless population, who previously may have been not able to fully recover where they were, either in shelter or in a hotel situation. And so this really gives them the care they need with medical oversight by staff in these private renovated houses in the center of Rockville. So really exciting prospect that opened a couple months ago, and they accept referrals from the hospital when patients are being discharged. We do want to look at expansion of MIH to accommodate low acuity calls in the field. So we want to focus on how we can divert folks away from the emergency departments and really free up those beds for people who need them for true medical emergencies. So we're looking at opportunities for alternative destinations as well as treatment in place, and we'll get into those in a little bit as well. Hilly, are you able to speak? Is your sound working again? Oh, great. Okay.
Yeah, I'm back.
Jump
Sorry
in.
earlier, I don't know what happened. Okay, so I'm going to address the mobile integrated health responsibilities and targeting super users. Most commonly, we deal with residents who have behavioral health issues, substance abuse, basically, again, the homeless, as she just talked about, people with no fixed address. Most times, most of our calls are also surrounding people who need lift assist, adults or disabled people who are living alone or with family members, and they are unable to, move from one location to the other. Those are some of the calls we get, or people who living alone or with their loved ones that may experience a fall. Also isolated elderly and disabled people. Again, majority of our residents in the county either live alone and think they can manage themselves by themselves. And so we deal with a lot of those residents. How we find these residents, most of the referrals come from our clinicians, our EMTs and EMS services in the county, through the EMED system, the FIRE app, or through phone or email. As EMS or as providers, whether clinicians, nurses, we are considered mandatory reporters. And so when when our EMTs go out, or even in the hospitals, we get them to refer us if they have a concern of a particular resident who's showing up at the hospital or who they responded to. We also find them by going through an app, First Watch surveillance data. And we also have the data mining and community referrals, as I talked, the hospitals, doctors' offices, rehab centers, dialysis centers. We get referrals from all over that we target. And these users are the ones who frequently will call us because either they don't have doctors, or they are neglecting their care. They're not following up with the physicians or primary doctors or their services that they have in place. And then going back to the next screen, now we have MIH referrals. Who should be referred to MIH? Frequent or inappropriate users of 911. So what do we mean by frequent or inappropriate users of 911? When you look back to the next screen, the last screen, we talked about people who calling for lift assist. So if you're at home and you're an elderly person, have mobility issues, and you want to go to the doctor's office, but instead of getting help either from a relative or, a friend, they'll call 911 to ask to lift them from upstairs to the car. And then when they come back from the doctor's office from the car to their bedroom. And that is considered an inappropriate use of the 911 system. Frequent users, again, are people who may also probably, they fall most often, but then when the EMTs go there, they don't want to go to the hospital. They don't want to go and get examined. But yet, as soon as the EMTs, leave, there's another call coming through that they are, again, taking a fall. Also, people that we should refer to MIH are people with mobility issues, people who lack resources. A lot of people in the county, a lot of residents in the county don't know how to access the resources to help them, whether it's aid services, community resources to help with whatever concerns that they have, primary doctors. So those are the kind of people we also encourage our EMTs and partners to refer to us. People with mental health concerns who may or may not have, counselors or psychiatrists or psychologists that they are working with are also eligible to be referred to the MIH. Substance use concerns, people either abusing alcohol or drugs, recreational drugs, are also people we look for, who target, to have referred to us, because sometimes, again, most of these people don't know how to access the resources to help themselves. And so when we get these referrals, we then work on, connecting them to the resources in the county to help address the issues, because sometimes they really do want to stop, but don't know how to. And so we encourage those referrals. Also, people of housing instability, our homeless, of course, and people who needs medication management. We have elderly residents in the home who, even though they follow up with their primary doctors and they see their physicians and other care providers, but they, every time a patient is admitted to the hospital, of course, the medication changes. I recall a patient who every time she was admitted, maybe every week, and every week her medication changed. And when we got to her house, she had 10 different blood pressure medications. And because there was no reconciliation of her medication, she continued to take all 10 of the medication because she was given those medications. And so that's, people like that, when you go into the home or you see that they have that kind of a problem, you refer them to us, and, either me or Jennifer, we go then out to them to help, maybe contact the primary doctor or provider to figure out what medication should they be taking and what that they shouldn't be taking. Those kinds of referral we also appreciate. Those who are self-neglecting, who don't recognizes their health concerns or mental concerns or substance use concerns, but refuses to take charge and take care of themselves. We welcome those kinds of referrals also. And then when clinicians don't know when our clinicians don't know where else to turn, they call us, which, we also welcome, because sometimes the cases out there, every patient or every resident is different. They are not typical signs or reason to say, let's refer this person, or, oh, maybe this is not good. So if you have a concern and you doubt it, just reach out to MIH, and we also can reach out to that client and try to work out with them. Avatar.
I know everyone always likes to see the numbers. Who's your highest utilizer? So I just ran 2021 numbers. And so if you remember, we had about 91,000 EMS dispatches, resulting in, to be more specific, about 66,000 EMS transports in 2021. And out of those 66,000, 166 patients generated 2,700 calls. So these are kind of the highest of the high utilizers, people with 10 or more calls throughout the year. We don't necessarily intervene with every single one of these patients. Sometimes these are things that work themselves out, right? Someone gets discharged from the hospital and has legitimate medical issues that result and they need to be addressed. And so they call 911 multiple times, and then the end result is that they end up getting put into a facility that can adequately care for them. So this is not necessarily 166 MIH patients, but just in terms of overall utilization. Our top super user was the same. We had the same woman in 2020 and 2021. In 2020, she had about 178 calls, and then she topped herself in 2021 with 193. And every single one of those calls was a lift assist. She never went to the hospital. She didn't need to go to the hospital. She wasn't hurt. She was just sliding out of a wheelchair. And despite Pilly's best efforts to get that lovely woman everything she needed to stop falling out of her wheelchair, she is quite happy with the broken wheelchair that she has and doesn't want to stop using it. But we were able to talk to her and really just have a conversation with her about what constitutes a 911 call and what doesn't, and when she should or should not call us. And year to date, she's at less than 10 calls so far for 2022. So we're really thrilled about that. She was very receptive to our feedback after several meetings with her, and has taken it to heart. In general, we saw a continuing trend in 2021 of behavioral health and substance use calls increasing. we had a pretty drastic increase in 2020 from 2019, where we saw a 42% increase in behavioral health and substance use calls, despite the fact that overall call volume for fire rescue dropped by about 10,000 because of COVID. So even with that sharp decline in overall transports, we still saw a really high number of behavioral health and substance use disorder related calls. And then in 2021, that number continued to increase. So we went from about 10,500 calls in 2020 to over 13,000 calls in 2021. So it just, again, kind of drives home the point that we need to find continuing and evolving solutions to address the needs of behavioral health patients in our community. Pili, you want to jump back in?
Yeah. Okay, so again, we cannot always immediately stop, not always, but we cannot stop 911 callers from calling 911, or our frequent users, or what we deem inappropriate use of the 911 system. What we do with the MIH is we try to educate them as to, when they should call, or why they should, when it's more necessary to call versus when it's not necessary to call. In the instance of lift assist, if you just need a lift from your bedroom to the car, that's considered an inappropriate use for 911. But can we stop those calls? No, we cannot stop those calls. Our clinicians still go out and respond to those calls and, help the residents. Unfortunately, also, we cannot compel our competent residents who refuse to seek assistance, whether it's from us or from outside sources, to stop calling 911. They will call regardless, and those are some of the limitations that we have with our MIH program. Other limitations are reporting cases to us doesn't always absorb this EMS clinician or the mandatory reporter status. Even though you call MIH to let a patient, to let us know that, or refer a client to us, it doesn't absolve you of your responsibility to still report. If you need to call APS, or if you need to follow up or move it a little bit, above that level, you still should do so. Because again, because we cannot stop 911 calls and we cannot compel residents to do what we are recommending. And if you see a concern and a need, you should still, further maybe reach out to APS to then have a more involved team with that client. Also, our limitations is hoarding homes. We cannot clean the home. We will maybe call the task force if you are in an area that has a hoarding task force to investigate your hoarding. We can send out the fire department to look at your fire codes to make sure you are up to date. However, we ourselves don't go into your home to try to clean it, or can't really do much when it comes to hoarding situations. We can also guarantee a patient will be investigated by APS. APS, as an APS worker, APS has its own criteria that the resident has to meet. So just because you report a resident to APS doesn't mean APS will take up the case. APS, our intake workers, will evaluate based on the circumstances or what the report is, and do their own investigation prior to bumping it over to an APS social worker to before they accept or reject the case. So because you report a case to APS doesn't mean it's always going to be accepted by APS. So those are some of the limitations, unfortunately, that MIH has. And so we do most we can on our end before we even escalate the cases to APS. Avatar.
Yeah, so these are just some screenshots of our electronic health record. It's called eMeds. It's run by a company called ImageTrend, and this is the same EHR that's run by the whole state. So every EMS agency in Maryland uses this same system. So we basically have an option for clinicians to select this yes button when they're doing their actual report, which is either done in the back of the ambulance with the patient, or after the call, they'll be in the hospital. There's usually a little room where they can do their charting. And so we'll ask, does the patient require follow-up from MIH? And if they say yes, then a little worksheet will turn red. And they are taken to a further sheet, which will be after this slide. And then we also have an EMS referral tab in our system reporting program. So this is like after the call, after you get back to the firehouse, you do a report to say exactly what equipment you used and which pieces of apparatus went on a call. And so we also have a referral tab in here. So we've really tried to make this as easy as possible for clinicians to send us information without putting too much additional strain on them, because we know they're busy and it's easy to forget to submit a report. So we've tried our best to make it easy, and a lot of the stuff is pre-filled out. So we try to drag over relevant information like address and unit number, incident number, et cetera, so they don't have to retype all of that. This particular system that we created, the nice thing is it's behind a firewall where as soon as you hit this submit button, anything that's written in here disappears. So it's not stored anywhere permanently. It does generate an email that comes to the MIH team, and then we can read that email and respond to it, but the information itself is never stored. So this allows our clinicians to share HIPAA information, specific names and date of birth, contact information, and specific information about circumstance without having to worry about it not being protected properly. And this, I can share this again at the end, but this is the email address that comes to all of the MIH team. So if you ever have a question and you're not sure who exactly to email, or you can't remember any of our names, but you remember this, it's mcfrs.vulnerableadults@montgomerycountymd.gov. We also work with our clinicians on trying to get more detail out of them. It's great for a clinician to tell us that an apartment was cluttered. But then when we say, well, what does that mean? What does cluttered mean? What does that look like? Then we can get into the hoarding scale. So we do share this with clinicians when they tell us that one of the concerns is around hoarding. We'll share this image and say, okay, on this scale, what did it look like? And if they say it looks like a number 2 or number 3, like, okay, the floors are pretty much clear. They have some piles here, but it's nothing too concerning. But obviously, when you get to this bottom row here and all walkways are impeded, windows are impeded, exit doors are impeded, we're getting into concerns about fire hazards, weight load bearing of the floors, right, if something happens, and safe egress for the patient, safe entry and egress for our crews. So this has really been helpful to be able to share with them. Hilly, you want to jump in?
Yes. Okay, so now our next slide talks about the efforts to increase APS referrals. Again, as mandatory reporters, we must do all that we can to reach out to APS. Even if we don't think the case is going to be accepted, we should still refer if there is a concern. We, educate and encourage our EMS service personnel, and as a model for APS, we try to go the path of the least resistance, where when we meet a patient or resident, I keep saying patient, I'm a nurse, so we don't always just want to remove them from their home because they are self-neglecting, or because they are falling several times, or because, they want to call us for lift assist. We always want to try to see how we can mediate the concerns in the home by either involving the family member or bringing in resources before we, go to the extreme. So our goal always with the EMS clinicians is to follow the path of least resistance. Also, there may be gaps in the report to APS. So the EMTs or the hospital may call, and because they don't have all the information, usually when they call in, it's most times it's what I've seen, and then I'm calling APS to report. But I don't know whether there's family involvement. I don't know whether, you know, what's the patient overall circumstances. And so because of that, sometimes APS may miss patients who really needs to be investigated because of those gaps that we find, or we cannot really investigate to determine what really is the client's concern. And also most times when we have patients go to the hospital, even though the EMTs see a concern when they pick the patient up, or a family or neighbor, when they get to the hospital, they inform the nurse or the doctor or whoever is receiving the patient, the hospital may say, okay, I will do a report. You know, the police will also, you know, if the police is involved, they will also say, I will do a report. Or sometimes we assume that someone else has done a report. If I'm working with a crew member, in the instance of my partner, Jennifer, if I'm working with Jennifer and I see something, and I, you know, instead of making that report, I'm assuming she's made that report. And so again, because I assume sometimes weeks go by and a report is not made and the patient falls through the gap, and, you know, the situation becomes worse. Other efforts that we, you know, use to increase the APS referral is added visual aids to Firehouse and reporting software. So APS and MIH came up with a sheet, well, you know, that we listed. You see it on the next slide. Criteria that, okay, this is it. Criteria that our EMTs should be looking for before making the APS report. So when you go through this, and this is posted in all the firehouses in Montgomery County, the volunteer firehouses also, so that the EMTs are a little bit educated as to how and when to refer and what circumstances that they should look for in order to refer to APS. So sometimes it's best to refer directly to APS if these, you know, if there is a check on all of these on this flyer, it's best to refer to APS immediately instead of having to come to MIH and then, you know, before we take time to investigate and then do the APS. So when these concerns are there, go ahead and you know, refer to APS immediately. Also, we want to check access point to APS to make sure all roads led to a referral. When you call the APS team or the intake team to report a client or refer a client, don't just let it be. Don't just do that and leave it alone. You want to follow up to make sure, was this patient accepted again? APS has its criteria that, you know, on accepting or rejecting a patient. And so you want to follow up as a concerned provider. You know, did APS take that case? If APS didn't take that case, you could probably also refer the client to another resource, or, you know, then come back to MIH. But we always want to try to follow up to see whether our referral led to something else. Because sometimes when the EMTs go into the home, they may see a situation, they would take the telephone number, but sometimes those telephone numbers are not always accurate. It's either not the patient's phone number, it's either not the family's phone number, it's someone else, maybe a bystander who called 911 for that client. And so we try to reach out to that number and the number is disconnected. And you call several times and the number is disconnected. Of course, at that time, you then give up. And so again, these patients will fall in the cracks and the issues or concerns will not be addressed. So you want to make sure you have, you know, the information as much as possible to help ease the investigation for the investigator that is either calling or is going out to find the patient. Avatar?
Yeah, and we also found some phone numbers that people had stored over the years in their cell phone for Adult Protective Services, and they would claim to call Adult Protective Services and get a deadline or get a voicemail box. And we're like, well, that doesn't sound right, because we know what happens when you call APS in the county, and they're very responsive and it's a 24/7 line. And so it turned out there were some phone numbers that had been published years ago that just weren't accurate and weren't monitored anymore. And so we worked to close those down and redirect them to the right phone number. So that was also very helpful. We also did kind of prompt our clinicians. So this is that tail end of that worksheet. When a clinician says, yes, this patient needs follow-up from MIH, we say, okay, well, tell us why. And so this worksheet will give them information that kind of guides them to tell us more detail, because as the more detail we get, the better, the less we have to hassle the clinician to get further follow-up. So a couple of these specifically say that an APS report is required, and that includes self-neglect and neglect or abuse by a family member or caregiver. So we've done that too, to again, just remind our clinicians of their mandated reporter status. Real quick, I wanna just breeze through these because I wanna get to the case study and leave time for questions. So Montgomery County is participating in what's called the ET3 program. It's run by CMS, and it's an innovation grant that runs through 2025, basically reimbursing EMS companies to transport patients to alternative destinations like urgent cares, or to treat patients using alternative methods like telehealth. So we have that. We've been doing it for a little over a year now in Montgomery County. We work with various urgent cares as well as Kaiser, CDU, and Gaithersburg to transport patients to alternative destinations. We also have a telehealth contract with USEX, who provides the medical staff, the doctors at the Adventist and Holy Cross hospitals. So off-duty physicians will answer the phone for us and then do a Zoom telehealth with a patient. In the future, we hope to expand this to include mental health. I've seen it as telemental health and mental telehealth. So either way, we would love to eventually include that in our toolbox as well, so that we can help behavioral health patients without necessarily having to transport them. We are working on a partnership with the Crisis Center to start transporting patients there directly instead of to the emergency department first. And again, that restoration center that we hope to build in the mid-2020s. The Crisis Center is another, really important partner of ours, and so we always encourage our clinicians in the field to utilize the Crisis Center whenever they feel it necessary. The Crisis Center is doing a really great job on those expansions and working on improving service to the entire county and region. So they are expanding the mobile crisis outreach teams, the MCOTs. They have the ability to get as high as 3 MCOTs right now from the normal 1 that we had before. If you just envision that, 1 mobile crisis outreach team that ran 24/7 to cover a population of 1.1 million people. I mean, it's just doesn't really cover the need at all for what our county has. So they're already working on expanding those, and they look to continue to expand. We remind people that there are no appointments needed for the Crisis Center. It's a walk-up service. You can go anytime, don't need a referral, and they do have social workers on site as well as psychiatric staff. So they really are a really great resource that we're very lucky to have. So I think we can kind of gloss through this real quick. Pili, do you want to go through any of this?
Okay, I can go through.
Okay,
yeah,
ahead.
So for APS, as an APS, someone being referred to APS, we consider anyone who is a vulnerable adult, 18 and above, who lacks the physical or mental capacity to care for themselves. And this is the COMA definition for vulnerable adult, anyone lacking the physical or mental capacity. So just briefly, for an example, because someone is disabled doesn't make them vulnerable. However, if that person is disabled physically, lacks that, has the physical incapacity, but has mental capacity, that person is not considered a vulnerable adult. So APS, you can refer anyone who is 18 and above with a physical or mental, who lacks a physical or mental capacity to care for themselves or is in a position of being abused. We have, APS has a lot of, programs and resources out there. If it's an we can do emergency placements for clients. We can put them in what we call adult care service, adult homes, adult daycare home, no, not daycare, adult homes where we have, we put them in, it's like single family homes, but we have them living instead of taking them to the nursing home or other services like that. Or also we can send them to skilled nursing facilities if it's an emergent case. Some of the limitations, however, that APS has is because, again, the adult has to lack mental capacity. When one has capacity, it makes it very difficult to do anything to help them. The client has the right as an adult to refuse services. They don't have to take or accept services from APS. And then when we have clients in nursing homes, skilled nursing facilities, DDA facilities or mental health facilities, of course, APS is limited. Our jurisdiction don't go beyond that. We cannot work with clients in those kinds of facilities unless maybe we put them, we sort of facilitated their, especially like for the skilled nursing facilities. We have a lot of patients who we may put in a facility because they can no longer take care of themselves, and we go through the process and then they end up in the nursing home. We follow them for a little while, but then after that, we cannot follow them anymore. We do not have the legal authority as APS investigators to make decisions for our clients. That includes placing them in higher level of care, taking or not taking the medication, giving away money inappropriately, etc. Again, if these clients have capacity, we cannot make those decisions for them. However, if they don't have capacity, one of the things that we can do, we have a guardianship program that we can then move the case, the APS case to see what guardianship can do to help that person, especially if they have no one who can help them, or if they lack capacity and are making bad judgment because they don't have capacity. Again, the word is having lacking capacity to be able to do anything for our residents. When they do have capacity, they have the right to say, I don't want this, don't help me, and we have no choice but to walk away. So APS versus EMS perspective, bridging the gap. As the patient has broken wheelchair and falls out almost daily, MIH gets her a new wheelchair that she refuses to use. Patient continues to call 911 for lift assist. EMTs go out and she continues to call 911, even though this case has been referred to MIH. MIH goes out, we try to maybe get the person a new chair, work with the Medicaid to get them a new chair, or work with some transportation company to maybe transport them, or a family member to, move them around, but nothing's still happening. They're still calling 911. So our EMTs, of course, get frustrated and wonder, but why isn't anybody doing anything? This patient is living alone. Why isn't anybody doing anything? And no one is doing anything, again, because from the APS perspective, this patient has been evaluated many times, and this patient has capacity. Even though this patient may be disabled, this patient may be living home alone, falling several times a day, self-neglecting, but this patient has capacity. We cannot force them to do what they don't want to do. We can try to encourage them and make them aware of the harm and danger to themselves, but we cannot force them to take our recommendations. There's a particular case with this scenario where the patient, we did everything, got her a wheelchair, got her a new motorized chair. She has care in the home 8 hours a day and I think few hours in the evening. But yes, she still continues to call 911 because she still continues to fall. She's aware of the dangers that she, is posed to her from her falls, but she continues to do that. Unfortunately, APS or MIH hands are tied and we can't do much to assist this patient, but just be, I guess, of support. Respond every time she calls 911. Okay, so that moves us into a case study that we did in October of 2020. Our dispatch team was called for ALS2 non-breathing patient who was noted to have change in color of his skin and also semi-conscious. When the crews arrived, on the scene, the neighbors, the family lived in a single family home. The neighbors in the area were, sort of gagging. I guess the odor or whatever was in the area was not pleasant. So the crews went in and discovered the patient in the back bedroom of the house, which was only accessible by a single file path. Again, you going back, we looked at the hoarding situation. That home was fairly hoarded, and they only had a path to walk through to get to the patient. When they got there, the wife was there. The crew asked the wife what was going on. Of course, after observing the patient, she reported that the patient had respiratory issues and started to become respiratory issue a week ago. And she provided the medical history, not that much. Okay, and then noted that the patient is paraplegic. The wife, who is the primary caregiver, also has her own issues. I think she had a bad back, and she was also battling cancer. But because of this gentleman's paraplegic condition, where he's not able to tell what's going on from his neck down, he, I think, believed that his wife was taking very good care of him and the best of care. So the patient was in the hospital bed. When the EMTs arrived, after assessing the patient and doing what they had to do to keep him safe, either putting a O2 on his nasal cannula on and all that, they then proceeded to assess further. And when they did that, they realized that this patient had been laying in his feces. I hope you guys are not eating your lunch or something, but he was laying in feces that was several inches thick. He had a lot of chalk pads under him. The condition was just bad. He had maggots, flies all over the place, all over him. Now, this patient, unfortunately, again, because of his paraplegic status, they didn't know what was going on down there. He couldn't feel. And so he always, I'm sure, believed that his wife was taking very good care of him. But the wife, who's seen that condition, maybe she was doing her best. We can't tell. Again, this is where information, we have misinformation because we don't really know what's going on. So we can always jump to a conclusion. However, this is where we come in as APS workers and investigate when these cases are referred to us. The patient, on the other hand, was alert and oriented. He told clinicians why he was paralyzed. And then he, of course, reported that he had not eaten in several days and that he couldn't keep water down every time he ate. This patient probably weighed approximately 300 pounds. After assessing the patient and seeing the condition, and I'm sure the EMTs connecting with their duty officers, they made the decision to take the patient to the hospital, of course, because he was called for the call was made for respiratory status, which they were able to confirm. So the clinicians then noted that the patient was warm. However, he denied any medical history or taking any medications. Now, for a paraplegic in this condition, I'm sure he probably had medications and other things to take, but may have not been receiving it, or, This patient was then transferred to the hospital where he received immediate medical interventions. He was hypotensive and he was tachycardic. His heart rate was high, his blood pressure was very low. We eliminated the pictures on this case because it's gross and we didn't want to ruin your afternoon. But basically, this is the scenario of this case and how the EMTs and MIH and the APS team work together in the county to try to resolve concerns like this. Abigail?
Yeah, so the hospital was just able to confirm what the patient already told us, that he was a paraplegic. He had gotten in a car accident in 1969 and was bedbound, mostly for the last couple of years. He had been in a wheelchair before that. His wife had a cancer diagnosis about 2 months before all of this started. And he was diagnosed with sepsis, cellulitis, gangrene, and osteomyelitis. that condition did not manifest itself overnight. He obviously had been laying in bed in that condition for a very long time. But like Pili said, because he was paralyzed, he didn't feel anything in his legs or feet. He had no idea what was going on or how bad it was. He ended up having some toes amputated due to the extent of the infection that was going on. So we wanted to kind of ask people what they would do next, but I know we're running short on time. So basically the crews who were on scene from the fire department did a really great job. They made sure that police were on scene. They made sure to make a report to police about what they found, how the condition that they found the patient in. They made sure that the police got pictures of everything. And the police did a really great and thorough investigation. This was also a case that was discussed with the Elder Abuse Vulnerable Adult Task Force. So we all worked together with the attorney's offices. And after the investigation was complete, they charged her with abuse or neglect of a vulnerable adult in the first degree. She did post bail right away. The patient also had family. They weren't in the area and they were from his first marriage. So the wife that he was married to was not their mother. And his kids kind of rallied together to support him in his time of need and make sure that he was cared for. So they started divorce proceedings and got a protection order issued. This is the patient. He gave us full permission to share these photos. So he is a lovely gentleman. He was in such good spirits considering everything that happened to him. He was just grateful for the support from everyone and just happy to be there. And he was discharged to a local skilled nursing facility for ongoing rehab and care. His divorce was finalized late last year. His wife or ex-wife pled guilty at the end of last year and was sentenced just a little bit ago to 7 years in jail, but it seems like all of that was suspended and she did get 5 years probation. We're not sure about the status of her medical health and how she's doing medically. But the family did move the patient down to be closer with him. So once he was stable and had rehabbed enough, they moved him down to be with them. And this was him 8 months after the original incident. So this was a really great example, like Pili said, of how APS and fire rescue worked really well together to make sure that this patient was cared for. It started from the moment the clinicians arrived on scene and determined that the patient needed more help, and they did everything in their power to alert and notify the right people and make sure that the severity of the situation was appropriately conveyed. So we really appreciate their efforts. I put up some resources here, and Sydney's can share all of this with you guys so that you can take a look at it. But there are some resources about MIH here. Finding MIH programs near you. There are several across the state of Maryland. If you're outside of Maryland, Googling, MIH and your county is helpful. And it could also be called community paramedicine instead of mobile integrated health. And I also added the link for the Gaithersburg Hoarding Task Force because I know that people often have questions about hoarding resources. So we'll open it up to questions. These are contact emails for the MIH team. If you guys have any questions or thoughts or anything that you need support-wise, please feel free to reach out to any one of us. Just firstname.lastname@montgomerycountymd.gov.
Perfect. Thank you, Avital. We've had a lot of questions coming in, a lot of really good ones. But just as I pull those up, I just want to comment again about the case example. Often when I'm doing community education, people say, well, I think the caregiver is just really stressed and that's why she's not providing enough care, right? And in this case, the wife, she had the cancer, she had things going on, and I'm sure that could have been an excuse that she was using for folks that she was talking to. But that case just shows, regardless of the reason that the neglect is happening, it can be extremely, extremely serious, and that APS call still needs to be made. So one of the first questions, we had a few questions along those lines, were about confidentiality and any agreements that you have from the individual to reach out after that EMS call. So someone was saying that they have something similar with their EMS program, but if the person doesn't agree that their contact information can be shared, they can't really do anything. So what is your confidentiality agreement between partners?
Yeah, that's a great question. So we do have MOUs with internal partners. So if we have for example, we have an MOU with the Elder Abuse Task Force. There's, an MOU with Adult Protective Services. We're working on an MOU right now with the Crisis Center to be able to share information. And then outside agencies, we do a BAA, a Business Associate Agreement, that is run through our legal team. So we have MOUs and BAAs with all the hospital partners, for example, so that we can openly share protected information about relevant patients who, are applicable to both parties.
Someone also asked about, and feel free to say you guys, but what of the programs in the country doing MIH is kind of like the gold standard? Like, who are some of the leaders in this field throughout the country that people can really look to?
I personally always love staying up to date with Texas programs. Texas just has a different model for doing EMS. They have individual medical directors in each jurisdiction, as opposed to having one oversight licensing agency like we do here in Maryland. So what that means is that their individual jurisdictions can really get into some crazy pilot programs. There is a company called MedStar Health, not related to the MedStar up here. And MedStar down in Fort Worth, Texas, has a really great community health approach to 911 services. They're a private ambulance company. They run the EMS calls for Fort Worth, but they also are able to do things like nurse triage at their 911 call center. So they have nurses there who can triage patients and determine, do you even need an ambulance to begin with, or can we talk over the phone? They get subscriber information from insurance companies. So they have, for example, let's say Anthem will download all of their relevant patient information into MedStar's system for dispatch. So when someone calls 911, you're not just seeing past 911 call history or their location history, you're seeing their medical history. And so you can actually have a conversation with the patient to adequately triage them over the phone and say, oh, you're calling for back pain today, Mr. Smith. I see that you just went to your doctor 2 days ago for back pain. Is this the same back pain, or is this related to a new injury? No, it's the same old. I always have back pain. I want to go to the hospital. My doctor didn't do anything. Well, they also have partnerships with the urgent cares in the area, and they have a direct line to the urgent care. So what they can do is they can say, let me schedule you an appointment right now for the urgent care. I'm going to send a Lyft or an Uber to come pick you up. They'll take you to the urgent care. The urgent care has all your records already. They'll see you right on a private entrance. You don't even have to sit in the waiting room. They'll help you and get you squared away, and then we'll send you back home in a paid Lyft or Uber. So they're really innovating in terms of these ideas of what constitutes an emergency. How do we make it easy for patients to really get the best experience? And how do we take advantage of ultimately the benefit for everyone, right? At the end of the day, the insurance companies are concerned about dollars and cents. And so to pay for, a Lyft or an Uber, or to pay for a nurse to sit at, their center to do triage efforts, really pays off in dividends in the savings that they see for patients avoiding the emergency department. So I always like, San Antonio has a great program. Their restoration center is fantastic. We're looking at that as a model for ours here. And then Fort Worth, Colorado has some really great programs. Connecticut has a great MIH program in New Haven. And they're focusing a lot on behavioral health, and they have a social worker and a police officer who go do follow-ups on patients in the field. Even, here at home, Frederick County, I'll give them a shout out. They just started a new mobile crisis team that has a paramedic, a social worker, and a police officer, all working together in one unit and going out to handle mobile crisis intervention. So things like these, they're happening all over the place. It's really hard now to quantify who's doing what, but those are a few.
Yeah, thank you. It sounds like there's a lot of great programs out there. And we have folks on the webinar today from all around the country. So maybe some of you are in those states. And if you didn't know about those programs before, you can go check them out. So we had another question about calls related to dementia and how EMS folks are trained on identifying people living with dementia and kind of meeting their needs and stopping that from being a hospital ER trip if that's not really what's necessary.
Yeah, so dementia is always a kind of tough nut to crack because it can have so many different presentations, right? And people can respond very differently. You can have someone who's very docile. You can have someone who gets very aggressive and agitated, right? And then you have maybe times of the day where they're totally lucid and then times where they're sundowning. So it's really comes down to a good clinical assessment, right? We ask all of our clinicians to do a very thorough assessment on their patients, and that's reflected in the paperwork that we ask them to complete. So they're prompted to do those things. So to talk to the patient about why did you call us today, and why do you think you need to go to the hospital? What's your medical concern today? And then to really be observers of their environment and their surroundings to see, it looks like, I just checked your fridge and I don't see a lot of food in there. What did you eat today? Right. And find out things like that, do a little bit of investigating of their own. So we don't have, specific, like dementia aspect to our training, but we do have opportunities for clinicians to take continuing education credits in something like, working with the senior population, those with Alzheimer's and dementia. So we have to do 60 hours plus of Con Ed every 2 years. And we have some leeway in what that constitutes. So there's classes that there's a national industry that basically regulates what we cover, and then we can kind of maneuver within that and add additional subject matter. So we do focus on that. And the police department in Montgomery County has a really great Alzheimer's and dementia outreach team within their community outreach. And Lori Reyes is the officer who's in charge of that program and has done a really great job with Alzheimer's and dementia identifiers, like yellow wristband that people can wear that kind of lists that they're Alzheimer's dementia patients, and you can even put like contact information in this little bracelet so that, phone number and address and things like that. So if they wander out of their apartment or their home, someone can make sure they get back to where they need to go. So things like that have really helped our clinicians.
Great. I also saw just in the chat box that the National MIH Conference looks like it's next week, and someone put the link in there as well. So if you're interested in learning even more about these types of programs and maybe what's in your own community, you can check that out. All right, I'm just looking at some of the other questions here. One was, and Pili, this might be more for you, how you talked a lot about capacity. How does APS check someone's capacity? And if the person does lack capacity, but they don't have guardianship, where are they in that kind of in-between period in order to make sure they're staying safe?
I actually responded to that person.
Oh, okay, sorry.
But yeah, no, if the person lacks, unfortunately, APS cannot determine whether one has capacity or not. However, if the person is able to make decisions, just going back to the example of this paraplegic, he physically lacked capacity. Did he have mental capacity? Well, you could say yes and no, because when one has mental capacity, that means they are able to get up and do what they want to do. They're able to take care of themselves. Now, APS do not determine whether one has capacity or not. However, we have clinicians, physicians, and psychologists and psychiatrists we can contact to evaluate if the person have capacity. That is, if the case is out of going to guardianship. And in the meantime, in order to do that, when guardianship is involved, APS being in that role would then probably place the person in a adult foster care home while, those processes are sought out.
Perfect. Thank you so much. Thank you both. This was such a great hour and a half to hear more about your program. And I'm just going to share, if you could pull that up again, Avital, just some upcoming Elder Safe events for those of you that want to join us again. Next month, we're going to be looking at older adults and suicide, and we're partnering with EveryMind here in Montgomery County to do an introduction to screening and intervention for older adults and suicide. And then in June, June 15th is World Elder Abuse Awareness Month, but we'll be honoring that really all year, but also all month. And we're doing a webinar with some of the other programs here in Montgomery County and across Maryland to look at elder abuse prevention and intervention through a trauma-informed lens. So just as a reminder, if you are someone who needs continuing education credits, use this last minute here to make sure that the name that's showing up for you on Zoom is your full name. If not, make sure to rename yourself. You have to have been present for the entire live webinar, and you can request that certificate and the evaluation following the webinar, and they'll be emailed out to you after. Thank you all so much for joining and for all of your great questions and staying involved. And thank you again to Avital and Pili for sharing your time with us. I know that you are both really, really busy, so I appreciate you coming on and sharing more about your program.
Thank you for the opportunity.
Thank you all. Have a great day.
Thanks, everybody. Thank you.